Welcome all. We begin with the second talk article discussion. Acquired heart disease in pregnancy. Okay. So, what is the incidence? Incidence is increased. This is mainly because of the increased maternal age and the diabetes and obesity incidence is also on rise. Okay. Valvular disease, among the valvular, rheumatic is still the most important cause of acquired heart disease. Okay. Myocardial infarction and peripartum cardiomyopathy will have high maternal mortality. Okay. Management is a symptom based plus multidisciplinary team is important. So among the valvular causes, rheumatic is still the important cause for the acquired heart disease, and other are what we have seen myocardial infarction and cardiomyopathies. They are have high maternal mortality. Okay, so coming to the causes of acquired heart disease, they may be valvular, ischemic, cardiomyopathy, and arrhythmias. Among the valvular, mitral stenosis, mitral regurgitation, aortic stenosis. In general, what we should remember a dictum that regurgitant lesions are better tolerated than the stenotic lesions. Okay, so MS and AS will have a worst outcome as compared to the MR. Okay, so ischemic myocardial infarction we have just seen in detail. Then cardiomyopathy, it may be dilated, hypertrophic, or peripartum. Peripartum, there is a separate talk. We have discussed that. I'll give you the link for this article also. Then arrhythmias, it may be supraventricular tachycardia, ventricular tachycardia, or it may be atrial fibrillation. So again, there are SBAs and EMQs which are asked from this particular talk. So please listen carefully. Valvular heart disease, as I have already mentioned, regurgitant lesions are better tolerated than the stenotic lesions. So stenotics are poorly tolerated. So mitral stenosis, we'll see. In mitral stenosis, there is increased heart rate and increased cardiac output, and across the mitral wall, there is increase in the gradient. That will lead to the increased left atrial pressure, and that will lead to the pulmonary edema. So this is what is the pathophysiology. The clinical presentation will be dyspnea, orthopnea, PND, pulmonary edema, and complications will be atrial fibrillation, heart failure, pulmonary edema. Now, if this, what is the management? In mild cases, just observation, maternal parameters we need to observe. If the patient is symptomatic, diuretics plus beta blockers can be used. If there is atrial fibrillation, cardioversion for the rate control, and in refractory cases, balloon valvuloplasty is required. Okay. So severe MS, less than 1 centimeter per square area, pregnancy is to be avoided. Okay. The next is a mitral regurgitant. Okay, so we know that regurgitation will be better tolerated than the stenotic lesion. So generally it is well tolerated because in pregnancy there is a decrease in the systemic vascular resistance. So patient will often be asymptomatic. So asymptomatic will not require treatment, just observation and multidisciplinary management. But if there are symptoms of heart failure, then diuretics, nitrates, and hydrazine, these are the drugs of choice. Then mitral valve prolapse, that is the commonest one. Okay, so it is seen in 12 to 17% of cases. If there is no regurgitation, it is benign and does not require intervention. Okay. Then the severe will be the aortic stenosis. Okay. This aortic stenosis will have a worst outcome during the pregnancy because there is a fixed obstruction. It cannot, the heart will not be able to increase the cardiac output, which is the demand of the pregnancy as well as labor. There is increase in the left ventricular pressure, and complications will be angina, heart failure, and arrhythmias. So high risk feature will be symptomatic patient, pressure across the valve gradient more than 80 millimeters of mercury, and if there is a left ventricular dysfunction, these are the high risk factors for the poor outcome. Okay, symptomatic patient, gradient more than 80 millimeters of mercury, and left ventricular dysfunction. So if the symptoms are mild, observe. Symptomatic patients will require a bed rest, and in severe cases, we have to do the valve intervention. Okay. So in mild cases where the valve area is more than 1.5 centimeter per square and mean gradient is less than 20 millimeters of mercury, no active intervention is required. But however, regular antenatal follow-up, periodic 2D echo, and cardiology follow-up will also be required. Avoid excessive fluid overflow because pregnancy is usually well tolerated because cardiac output increase can be compensated. Okay. Second category is symptomatic aortic stenosis. In these cases, bed rest plus medical management. Patient will have the dyspnea, syncope, angina. So bed rest will reduce the cardiac workload. Oxygen if required. Diuretics we have to be cautious for pulmonary congestion. Then beta blockers if tachycardia is present. However, we need to avoid hypotension. It can reduce coronary perfusion. and avoid overdiuresis also, because it is a preload dependent lesion. This aortic stenosis is a preload dependent. So with the diuresis, preload will be reduced. Okay. Then AS is a fixed cardiac output lesion. Heart cannot increase the output during the stress. That is why there are symptoms. If it is a severe aortic stenosis, then we need to go for valve intervention. So if the valve is less than 1 centimeter square or mean gradient is more than 40 millimeters of mercury, we need to go for intervention. So severe MS with symptoms, evidence of left ventricular dysfunction and refractory heart failure, we will go for valvular intervention. The option will be balloon aortic valvuloplasty, preferred in pregnancy. It is a temporary measure done in the second trimester. That is the safest period and less invasive. Okay. Then you have surgical valve replacement, but it is rare in pregnancy, high maternal and fetal risk, and considered only if life-threatening and no alternative. So if the option is there, go ahead with the balloon aortic valvuloplasty. And if it is less than 1 centimeter square area and the timing is the second trimester, these are the things which you should remember. So take home message for aortic stenosis: it is a fixed cardiac output lesion. Tachycardia, hypotension, decreased preload, these are the dangerous things. Most dangerous time is a labor and immediate postpartum. Epidural use cautiously. Avoid sudden hypotension. Vaginal delivery will be preferred unless there is an obstetric indication. Okay. So mild AS, observe symptomatic patients. So if it is a symptomatic, go for conservative management, bed rest, careful medications, etc. And if it is a severe, then consider balloon valvuloplasty. Avoid cardiac surgery if possible, and balloon valvuloplasty is a better option. Then there are two types of valve. Prosthetic valves, there are two types. One is a bioprosthetic and another is a mechanical. Okay, these bioprosthetic valves are safer. There is a low risk of thrombosis and anticoagulation is not required. But if you go for mechanical valve, then there is a high risk in the pregnancy. Then there is a high risk of thrombosis, almost 45% risk of thrombosis with the mechanical valve, and anticoagulation is must. Okay. So as far as anticoagulation is pregnancy, especially if the patient is on valves, mechanical valves, then it is really a dilemma. What anticoagulant is to be used, whether to go ahead with warfarin or whether to go ahead with the low molecular weight heparin. Okay. If the warfarin is given throughout, that is better for the mother. There is a low risk of thrombosis, but the fetus is at risk because there is a risk of embryopathy, 6% risk of embryopathy. Okay. If we go ahead with low molecular weight heparin in the first trimester up to 12 weeks, the maternal risk is moderate, but it is safe for the fetus. So this is a better option, that in first trimester, you give low molecular weight heparin and then shift to the warfarin. Okay, because there is no risk of warfarin, embryopathy will be reduced. The third option is that you go ahead with the low molecular weight heparin throughout, but that has got a high risk of thrombosis, but it is safe for the fetus, because if you give low molecular weight heparin throughout, then also there are 25% chance of thrombosis. Okay, so balance maternal thrombosis versus the fetal risk and monitor anti-10A levels. Then endocarditis prophylaxis is required in all valvular lesions except MVP without MR. So if you are given a scenario where there is MVP without MR, these patients will not be requiring endocarditis prophylaxis. The next lesion is ischemic cardiac disease. It is rare, around 1 in 10,000. Mortality is around 37 to 50%. Management is a heparin, beta blockers, nitrates, but the first line will be percutaneous coronary intervention. Okay. Then cardiac arrhythmias. Causes in pregnancy, mainly because of the hormonal changes, increase hemodynamic load, and mild hypokalemia. Common types, it may be premature bits, it doesn't require treatment. Then supraventricular tachycardia, vagal manure, and adenosine. These are the preferred mode. Then atrial flutter, cardioversion will be required, and ventricular tachycardia, lignocaine and procainamide. These are the drugs of choice. Okay. Adenosine is safe during the pregnancy. Amiodarone is contraindicated. Beta blockers are safe. Cardioversion is safe. There is a question which was asked on the supraventricular tachycardia in the past, and the drug which was expected answer was adenosine. Okay, so do remember that this talk is important from examination point of view. Okay. Then cardiomyopathy, there are various types of cardiomyopathy. Dilated cardiomyopathy which is poorly tolerated. The mortality is around 7%, especially if there is a NYHA 3 or 4 category, and consider avoiding the pregnancy if there is a dilated cardiomyopathy. Hypertrophic cardiomyopathy generally better tolerated. So usually well tolerated if the patient is asymptomatic. Still there is a risk of arrhythmia and syncope. Then peripartum cardiomyopathy, there is a separate talk and we have already discussed. I'll give the link of this. Okay. Then left ventricular dysfunction is seen in peripartum cardiomyopathy. This occurs in the late second and third trimester and up to 5 months postpartum. There will be features of heart failure and diagnosis is by exclusion. Beta blockers, diuretics, hydralazine, and digoxin. These are the drugs of choice. Postpartum AC inhibitors can be used. Prognosis around 20% mortality. The transplant may be required. Other partial and complete recovery patients can have. So there is a high relapse risk in PPCM, and especially if the left ventricular dysfunction persists. Okay. So the take-home message is that mitral stenosis is the most important lesion. Regurgitation is better tolerated than the stenosis. Mechanical valves will require anticoagulation, and there is dilemma, but better to go ahead with the heparin in the first 12 weeks, followed by the warfarin. Then myocardial infarction, heparin plus beta blockers plus nitrates. Myocardial in pregnancy is managed with heparin, beta blockers, and nitrates for stabilization, followed by urgent PCI for definitive reperfusion. Doctor, this is the answer for that. So if the PCI is to be delayed, then we will use the heparin, beta blockers, and the nitrates. Okay. Then adenosine for the first line SVT. Amiodarone is contraindicated. PPCM is seen last month to 5 months postpartum. Okay. So in acquired heart disease, it is the stenosis, left ventricular dysfunction, and thrombosis risk will determine the outcome. Okay. So that finishes this talk on acquired heart disease in pregnancy. Doctor, we have few questions. Can you please go through the questions?
So then the answer of that question was correct. By the time PCI is available, we
Yes,
do the
yes. You should go
thrombolysis.
ahead with the thrombolysis. Correct. Yes.
Yes. A 28-year-old primary gravid at 30 weeks presents with worsening dyspnea and orthopnea. She is known to have rheumatic heart disease. Examination reveals a mid-diastolic murmur. What is the primary mechanism responsible for her symptom in pregnancy? So, this is A, reduced systemic vascular resistance, increased left ventricular compliance, increased heart rate leading to increased mitral gradient, decreased left ventricular. The answer is C, increased heart rate leading to increased transmitral gradient.
We are dealing with mitral stenosis. Okay, so mitral stenosis, C is the answer here. Pregnancy increases the heart rate and cardiac output. There is increased gradient across stenotic mitral valve. So left atrial pressure is increased. That will lead to the pulmonary edema. Next.
A 32-year-old woman at 26 weeks with known severe mitral stenosis presents with pulmonary edema. She is already on diuretics and beta blockers but remains symptomatic. What is the most appropriate next step? A. Immediate valve replacement surgery, increase beta blocker dose, balloon mitral valvuloplasty, start ACE inhibitor, or emergency delivery. So if she is not well on diuretic and beta blockers, then third thing, we should go for balloon mitral valvuloplasty.
Yes, that is a preferred. Balloon mitral valvuloplasty is a preferred, and safe period is a second trimester. So refractory MS, balloon valvuloplasty, treatment of choice in pregnancy, surgery avoided unless life-threatening. Next.
A pregnant woman is diagnosed with moderate mitral regurgitation and she is asymptomatic. What is the most appropriate management? So, moderate immediate valve repair, start anticoagulation, no treatment required, start beta blocker, elective early delivery. So, if she is asymptomatic, should we go for C?
Yeah, if she's asymptomatic, then we should be giving the conservative management. Okay.
Yes.
So regurgent
Yes.
lesions, there is a decrease in SVR, so they are well tolerated. So asymptomatic will not require treatment. Next.
Any treatment. A 29-year-old pregnant woman with aortic stenosis is being assessed. Which of the following indicates high maternal risk? So, This is asymptomatic murmur, gradient of 40 millimeter mercury, normal LV function, gradient more than 80 millimeter of mercury, mild exertional dyspnea. I think it is D.
D, gradient more than 80 millimeters of mercury. Okay.
Yes.
So any patient who is symptomatic, gradient more than 80 and left ventricle dysfunction. Okay.
Yes.
Next.
A woman with a mechanical mitral valve becomes pregnant. She wishes to minimize fetal risk. Which anticoagulation strategy carries the highest risk of maternal valve thrombosis? It is LMWH throughout pregnancy.
Yes, LMW is given. Almost 25% risk is there. Okay.
If
So
you give it
LMW is
throughout
throughout the
pregnancy, the
pregnancy,
risk of
highest thrombosis
thrombosis
risk,
is high,
warfarin, lowest
25%.
maternal risk, but the fetal harm is there. Next.
A 24-year-old woman at 20 weeks presents with sudden onset of palpitation. ECG confirms supraventricular tachycardia. She is hemodynamically stable. What is the most appropriate first line drug treatment? So it is adenosine B.
Yeah, B, adenosine. Okay. So SVT first is a vehicle maneuver, and
Vagal
that is a
maneuvers, then
non-pharmacological measure. And here in drug, adenosine is the first. Amiodarone is contraindicated. Okay. Next.
yes. A 35-year-old woman presents 2 months after delivery with progressive breathlessness and fatigue. Echocardiography shows left ventricular systolic dysfunction. No prior cardiac disease is known. What is the most likely diagnosis? So it is dilated cardiomyopathy.
She is presenting with 2 months after delivery with progressive. Why dilated cardiomyopathy, doctor? Why not peripartum
Uh,
cardiomyopathy?
Peripartum, sorry, I didn't see.
Yeah.
See, it's a
See,
peripartum
peripartum. Yeah,
cardiomyopathy. Yes,
peripartum car.
yes, sir.
Oh,
Yes,
last
sir.
month of pregnancy till 5 months. Okay.
Yes, sir.
That is a
Yes,
diagnosis
sir.
by exposure. Next.
A 31-year-old woman at 28 weeks gestation with rheumatic heart disease presents with worsening dyspnea and new onset atrial fibrillation. Echocardiography shows severe mitral stenosis, valve area is 0.9 centimeters square, and moderate mitral regurgitation. Which factor is the main driver of her acute deterioration? Decrease in systemic vascular resistance, increase in stroke volume, loss of atrial contraction with tachycardia, reduced preload, increased left ventricular compliance. It is the increase in the stroke volume.
No.
What is the
Stroke
answer?
volume.
I didn't
It should be C.
moderate
Loss of atrial contraction
contraction
with
with
tachycardia.
tachycardia.
Because these
Yes,
patients
yes.
will end up with atrial flutter, no? MS dominates
Hmm.
physiology despite MR. So stenotic lesion
So,
pathology will be more prominent as compared to the MR. So atrial fibrillation is mainly because of loss of atrial kick plus tachycardia that will reduce the decreased left ventricular peeling, leading to increased left atrial pressure, leading to pulmonary edema. So classic decompensation trigger in mitral stenosis. Next.
a 27-year-old pregnant woman, 8 weeks, has a mechanical mitral valve. She has been on warfarin with stable INR. She is counseled regarding anticoagulation option, which regimen provides the best balance of maternal and fetal risk. So a switch to LMWH in the first trimester, then warfarin until delivery. C is the answer.
C. So warfarin, lowest maternal thrombosis, but embryopathy in first trimester. So LMWH throughout
The risk
has
of
got a high thrombosis risk. So
warfarin,
best will be LMWH early and warfarin later. Next
warfarin
question.
embryopathy risk is 6%.
Yeah. Next.
A 36-year-old woman at 34 weeks presents with chest pain and ECG confirmed STMI. She is hemodynamically stable. What is the preferred definite management? First, thrombolysis with altiplase, Immediate PCI, emergency
Yes.
C-section, conservative. I think B
Why
is the immediate
emergency? No,
PCI.
no. Immediate PCI. Delivery we have to
Immediate
delay.
PCI, I was
Yeah,
immediate.
delivery we have to delay. If there is acute
No,
MI,
delivery. No,
yeah.
sir. I meant
So
immediate PCI.
yeah,
Emergency seizure we cannot do.
yeah, oh yeah. So pregnancy MI, PCI is the first line. Okay.
Yes, sir.
With thrombolysis, there is increased risk of placental bleeding. Okay.
Hmm.
Uh, there is a EMQ now. Yeah.
A
Can you see?
25-year-old pregnant woman presents with sudden onset of palpitation. ECG confirms SVT. She is stable and vagal maneuvers have failed. Most appropriate next step is adenosine.
Correct. So here they have given the vehicle manual is tried. So similar kind of question was there. Okay. Adenosine. Next.
A 30-year-old woman at 24 weeks with severe mitral stenosis remains symptomatic despite optimal medical therapy. So, what next is the balloon valvuloplasty?
So medical therapy is given. So option B.
B.
Okay. Balloon
Balloon valvuloplasty.
valvuloplasty. Yeah. Next.
33-year-old woman at 10 week gestation has a mechanical heart valve and wishes to minimize fetal risk. Most appropriate anticoagulation is change with LMWH.
Yeah. So
See the
option
option.
here will be
Option.
LMWH. She wants to minimize. So here it will be low molecular weight throughout the pregnancy, but there is going to be
No risk of
high
thrombosis.
thrombosis. But she is already on at around 10 weeks. Okay,
Mhm.
so warfarin ideally should have been changed by
Should be
6 weeks of
stopped.
gestation.
Yes. Mhm.
Okay, so
After
low
6 weeks,
molecular
it
weight
should be
through.
stopped.
So she wants to minimize the fetal. That is why this option is chosen. But ideally, it will be better to give warfarin in the first trimester, followed by
Sir,
this.
actually, the question was she wants to minimize the fetal risk. So if
Correct.
we give LMWH throughout pregnancy, it increases the risk to
The
the mother, but it is
mother,
safe for the fetus.
safe for the fetus. Yes, yes. That is
Yes,
why
sir.
they have selected this LMWH throughout the pregnancy. Okay.
Yes, sir.
Next. I think one question, one or two.
Yes. A 28-year-old primary gravid at 26 weeks presents with progressive breathlessness and episode of syncope. She has known aortic stenosis on examination, pulse 96, BP 110/70, heart systolic murmur, radiating carotids. Echo shows valve area of 0.8 centimeter square and mean gradient 45 millimeter of mercury. Despite medical therapy, she remains symptomatic. So here, the balloon aortic valvuloplasty
Yeah. So medical management is not sufficient. She requires, and
is still
emergency
symptomatic.
valve
So
replacement is also not a good option. Okay.
no,
Emergency
balloon aortic
that is not preferred.
valvuloplasty.
Okay. So
We
the
cannot do
option,
major surgery during
yeah,
pregnancy
balloon
on heart.
aortic valvuloplasty. She has got a
Yes.
severe AS, valve area less than 1 centimeter, grade more than 40, symptomatic, syncope plus dyspnea. Medical therapy is failed, and second trimester is safe. Next.
32-year-old woman with known moderate aortic stenosis is in labor. Shortly after epidural anesthesia, she developed dizziness and BP falls to 80 on 50. What is the most likely cause of her deterioration? It is B. Reduced preload due to vasodilatation.
Yeah, yeah, because it is after epidural analgesia. There is an immediate
Hmm.
drop. Okay. So reduced preload due to vasodilatation. Okay? Epidural will lead to vasodilatation, reducing the preload. Okay. In AS is a preload dependent lesion. Remember this. Aortic
Yes.
stenosis is a preload dependent. Decrease preload, decrease cardiac output, that will leading to hypertension. Okay. Next.
25-year-old pregnant woman with severe aortic stenosis is being monitored antenatally. Which of the following physiological changes would be most poorly tolerated? So, mild increase in blood volume, increase in stroke volume, tachycardia, slight decrease in cardiac output, peripheral vasodilatation. Mm,
Yes, aortic stenosis.
just a minute, sir. The peripheral vasodilatation.
It should be C answer, tachycardia, because what happens during in tachycardia, there is a decreased ventricular filling. Ventricular filling time is reduced. Okay.
Yes, sir.
So, and what
Ventricular filling
happens
is
against the
reduced.
stenotic lesions? These ventricles are already hypertrophied. So
Hmm.
they will develop ischemia, angina type of symptoms. Okay. So
So
answer
there
C
will
is
be
a
a decrease in the
tachycardia
cardiac output.
reduces the decreased diastolic filling time, leading to decreased coronary perfusion, leads to ischemia and reduced cardiac output. Okay. So in
Yes, sir.
S,
So
we have to
increase
slow the heart rate.
heart rate also decrease the cardiac output and that will cause ischemia,
Yeah.
worsen the
Okay.
symptom. Yes, sir.
So take home message is that AS is a fixed cardiac output lesion. Avoid tachycardia, hypotension, and decreased preload. These three things are to be avoided in aortic stenosis. Okay. Symptomatic severe AS, you go for balloon valvuloplasty, and labor, avoid sudden hemodynamic shifts. Okay. That finishes our talk article. Thank you.